My name is Michael Jewett, and I'm a urologist here at the Princess Margaret Cancer Centre in Toronto, where we have a large program in treatment and in research, and for that matter in education around kidney cancer. And we have worked with Kidney Cancer Canada to develop the Kidney Cancer Research Network of Canada, which is a network of clinicians across the country, researchers, patients, we call survivors, and their caregivers or carers, to advance the knowledge around kidney cancer and to improve the cure rates of kidney cancer in Canada.
I hadn't heard of kidney cancer before. How common is it?
So on a scale of the commonest cancers, it is not by far the most common cancer, but it's a cancer which has attracted a lot of interest recently, much more common in men than women. Tends to occur at the peak incidence in the 6th decade, so people in their 50s and 60s. And we've had some major developments in the treatment of this disease over the last 10 years with new drugs, new surgical procedures. So although it's a relatively infrequent disease, there are a lot of very interesting aspects that have made us work harder to improve the results of treatment.
What are the causes of kidney cancer?
We know that it's been going up steadily in all of the developed countries, including Canada, year on year over the last at least 10 years. And we're not clear exactly what the cause is. Some of it is detection through use of imaging, meaning ultrasounds and CT scans. But we know that heavy weight, obesity is a factor, and we know that there are some other environmental factors which may play into this, but we're not entirely clear why.
When you see a tumor in the kidney, do you always have to operate?
So we're detecting it more frequently, what we call incidentally, by accident. In the course of, say, someone has a pain in their abdomen and they get an ultrasound done, and then when we look at that ultrasound, we'll see something that wasn't suspected on the kidney. And these small, what we call masses or lumps on the kidneys, are very early stage kidney cancer frequently, and we can monitor those if there are other illnesses or if the patient is elderly, for example, because our evidence suggests that these grow quite slowly. These are not likely the cancers which are really life-threatening in the short term.
If the tumor does have to be removed, what does that surgery include?
So most patients with kidney cancer are treated by surgery, and the surgery traditionally has been removing the whole kidney, and the technical term for that is radical nephrectomy. Although more recently we have been interested and have been using a procedure that removes part of the kidney called a partial nephrectomy, which is largely removing the tumor and a little bit of the kidney with it. And that has been a big help to patients because losing a kidney exposes them to an increased risk of chronic kidney disease, or as we say, CKD, and that we know leads to cardiovascular disease, heart attacks, and even premature death in a proportion of these patients.
What are the benefits of having keyhole surgery?
So there are a variety of reasons. The first decision that we make is whether the kidney should be removed completely or whether part of the kidney should be removed. So if it's a radical nephrectomy, that is quite frequently performed laparoscopically or more recently robotically in some centers. If it's a partial nephrectomy, it depends on the size and location of the tumor, the institution, the experience of the surgeon, the comfort of the surgeon. So a lot of factors go into it. I think the key issue, though, is to think about doing a partial as opposed to complete kidney removal, and exactly how that's achieved is a second decision that's less important.
Under what circumstances would you recommend that a patient go for a second opinion, and how does a patient exactly go about getting a second opinion?
So this is a very topical subject in any rare disease, and it's because when a cancer in this case is not as frequently seen, an institution may not have all the resources needed. An example might be in an advanced case if there's a blood clot extending in the big vein from the kidney. That might require equipment that's not available. Some surgeons are less comfortable doing a partial nephrectomy as opposed to a radical nephrectomy. So I would say the first driver of a second opinion is around whether the treatments are available with the first institution or clinicians who make the diagnosis. There are other less clear indications. There may be a comfort, there may be communications, there may be just a sense of expertise around a certain procedure, because all of these are relatively rarer procedures compared to the common things we think about surgically, like gallbladder removal, hysterectomy, and these kinds of things. So I think the important thing is that people should not hesitate if they feel they want a second opinion for whatever reason, and ask to be referred. It's not difficult.
And does kidney cancer usually come back?
It doesn't come back usually when it presents as being in the kidney alone. So if the imaging shows a mass on the kidney and that's removed either with or without the whole kidney, that usually is a curative operation, and the patients need to be followed up at regular intervals. It can come back, but usually it either presents that way or the cancer is locally quite large and advanced.
Is someone considered cured after successful surgery?
So after surgery, we look at the tumor and we identify the exact type of tumor and the extent of tumor and what we call the grade of the tumor, which is the degree of malignancy. And from that, we can provide a pretty accurate estimate of the risk of that cancer coming back. And based on that, we will design through one of our guidelines a follow-up protocol, and we have a Canadian guideline for that. And it defines the frequency of the recommended visits and tests, including blood tests and x-rays or some form of imaging. And we do that over usually about 5 years.
So I was just going to ask you, so after 5 years of no recurrence, is somebody then considered cured?
So most of this recurrence, if it were to occur, will happen before that. It's not guaranteed, it can happen later, but generally around that time, patients go back and see their own family doctors if they have one, and they're followed in the normal way as part of their annual checkups.
How can I learn more about kidney cancer?
So there are a variety of internet resources. One that we refer our patients to is the Kidney Cancer Canada, KCC website. And there is a component of that that's interactive, so that there are members of KCC who volunteer to support people and help them. There are usually in the cancer centers and hospitals, there's usually information centers, variously called education centers or some such, and there's usually a volunteer that can help patients find information.
Dr. Jewett, as an expert in kidney cancer, what's your best advice for somebody that's been newly diagnosed with kidney cancer?
So personally, I recommend patients to come to see their clinicians, and I use that word purposefully to include the whole team, right from the nursing through the various medical specialties to the imagers and so forth, to come with somebody, a family member preferably, so 4 ears, 6 ears are better than 2 ears, and to then go away and read about it, become educated not just on the facts, but also how they can be their own advocate through this, and hook up with some of the groups out there that are there to help and that advocate for care and support care, and then come back and have an informed decision based on all of that information.